Good afternoon.
Okay, perfect. Let me know if you need anything.
I'm Representative Jim Dabney, Chair of the House Education and Finance Committee. I'd like to call this joint hearing of the Education Finance and Education Policy Committees to order. We're here today to focus through the voices of advocates and teachers, social workers, counselors, and others, practitioners, physicians, to hear the concerns that I'm hearing routinely on the impact of student mental health on education. Almost every conversation I have now with school personnel, school board members, and others on the challenges that they're finding and the barriers that students are increasingly facing in our schools, mental health is often the number one issue that they raise. It is regardless of geography, economics, or demographics. And Chair Joachim and I wanted to spend a day focused on those concerns and hearing voices from those on the front lines who are working with students and working productively and collaboratively with those students. With that, Chair Joachim.
Yes, thank you, Chair Dabney, for outlining that so well. And what we really wanted to hope to, especially for the Education Policy Group this week, last week we focused a lot on the schools, the rules they live by, the funding that streams they have, and some of the stakeholders in that area, issue area, and we'll be continuing that tomorrow on the issue area. But this week I really want us to focus on the kids and give you a good snapshot of the children that are coming to our schools and some of the barriers that they face, and was very excited that Chair Dabney has this high on his priority list, as well as looking at mental health, and look forward to having some great testimony and some discussion today. And with that, I think we'll introduce our first testifier, and that is Sue Abderholden. She's from the National Alliance on Mental Illness, NAMI for short, in Minnesota, and she's the executive director. Ms. Abderholden, could you please state your name for the record and then continue your testimony?
Yes, Chairs Joachim and Dabney, thank you so much for inviting me today. Sue Abderholden, Executive Director of NAMI Minnesota, and NAMI is a statewide grassroots organization dedicated to improving the lives of children and adults with mental illnesses and their families, and nearly 100% of our staff and board either live with a mental illness or are a family member, and I'm a family member. So I'm going to do a very quick, brief overview of kind of mental illnesses in children and what our mental health system looks like.
Ms. Abderholden, I hate to cut you off just a sec. I forgot to mention that after each section, we're going to give about 10 minutes for questions for the testifiers for you to ask. So go ahead, Ms. Abderholden.
Thank you. So you can see mental illness is very common, so 1 in 5, which I think is important. And of course, a lesser percentage, 1 in 25, who have a serious mental illness. But I think the important thing here is that 50% of all serious mental illnesses emerge before the age of 14. So if we wait until they're adults, we've waited too long. This is really a children's issue. You can see that even for kids, it's 20% of the population will develop a mental illness. We've got, 11% for kids who have a mood disorder, about 10% in terms of behavior or conduct disorder, and 8% with anxiety disorder. It's typically ADHD is one of the earliest mental illnesses that are identified, and then followed by anxiety. When you start to hit teenagers, then you start looking at some of the mood disorders, particularly depression. One of the things we know is that the juvenile justice system is actually the mental health system for kids of color. And so 70% of the kids in the juvenile justice system have 1 or more mental health diagnoses. The Child Mind Report just came out, and they actually calculated that nearly 50% of youth will have a diagnosable mental illness at some point during their childhood. 22% will have a serious impairment, and of those, only 7.4% will actually get treatment. We know that kids with mental illness who are in special ed actually have one of the highest dropout rates. So that's important to note. We have about 6,000 youth who are homeless on any given night. 57% of them have a significant mental health issue. And then suicide is really becoming a huge concern in the mental health community as a whole. It's now the second leading cause of death for people ages 10 to 34. In looking at the student survey, which I think is important to go back to see what are kids actually thinking and feeling, 1 in 5 showed signs of depression in the previous 2 weeks, which is really concerning. The percentage of ninth grade students who reported long-term mental health problems lasting 6 months or more rose from 12.5% in 2013 to 17.3% in 2016. And the percentage of 11th grade students receiving treatment also rose, which is good, 8.8% to 13.2%. We also have to consider, though, that the percentage of 11th graders seriously considering suicide went from 9.7% to 12%. That is very concerning. And in Minnesota, sadly, 9 youth between the ages of 10 to 14 and 39 youth between the ages of 15 to 19 completed suicide, and that is far too many. In 2011, the first time in 24 years, teen suicide rate was higher than the teen homicide rate. And I will say that suicide is up in all ethnic groups, but particularly with Native American youth, that's the highest. One thing that's concerning is that for many years, we said the prevalence rate wasn't changing. It was just that we were more aware. They're now saying that the prevalence rate is actually increasing. And it's not just in the United States, but it's across the world. I'm on a lot of different listservs from advocates across the world, and they're having problems in England and in Australia and in France and in Ireland not being able to meet the needs of kids. One thing that we can note here in terms of the emergency use is, so I was not able to get the 2017 data, but for the 2016 data, you can see that we had an increase in children going to the emergency room for mental health care conditions. So it was only just under 10,000 in 2007. It was over 19,000 in 2016. So we can see that there really is an urgency in terms of children's mental health. So when we tried to look at why our prevalence rate is increasing, no one really knows for sure. We do know that living in poverty in terms of causing toxic stress can really contribute to mental illnesses. Kids who are homeless, families that are homeless, things like that. But there's more research now being done around social media, and really concerned about the impact that that has on our kids' mental health. For kids who were really watching quite a bit of it, a lot of screen time, 14% were more likely to be depressed. 8th graders with heavy use, their increased risk of depression was 27%. And teens who spend 3 hours a day or more were more likely to have a risk factor for suicide. And part of it is it builds up anxiety, right? You're seeing kids doing, they're looking better on their social media. They're doing cool things, and you're not. If all your time is communicating on social media, actually being with real people creates more anxiety because you're not used to communicating and engaging with them. Sleep deprivation, we know, has a huge impact on the brain. Kids are up late with their phones. They're not getting enough sleep. That has an impact. There are some protective factors and risk factors, although this doesn't do it all, right? We know that there's a genetic component, but we do know that if we can be supportive of kids in the family and things like that, decrease poverty, that actually will be helpful to them. We can't protect, everyone talks about adverse childhood experiences. We can't protect kids from everything, right? I mean, deaths occur, illnesses occur, accidents occur, natural disasters occur, but what we want to do is support kids to be resilient. In terms of our children's mental health system, just briefly, so early identification is really important. We know that for any healthcare condition, you want to identify it as soon as possible and get the treatment because that leads to the best outcomes. We have child and teen checkups. We have social emotional screening in early childhood. We have had a focus on screening in primary care in Minnesota, and the clinics went up in terms of the number of kids who are being screened. We also are trying to train people who come into contact with children so that they're aware of some of those early signs. Minnesota was the first state in the country to require teachers to have continuing education on the early warning signs of mental illness, and recently we added 1 hour of suicide prevention. Foster care providers in Minnesota are now required to have training on children's mental health, and we do youth mental health first training as well so that people know what to do. This is a list, which I know for some of you far away are not going to be able to read, but I just want you to know that there are a lot of things. But I also want you to note that in red are the services that are only paid for under Medicaid and Minnesota Care and some state and county grant funding. And the ones that are just in the kind of the regular dark blue are what private insurance pays for. And I want you to see that there's a difference between what private insurance pays for and what public insurance pays for. It's also, people might know about TEFRA, the Medicaid program where middle-income families access it. There's actually a higher standard for families of kids with mental illness than families of other types of disabilities. So we have far fewer families on that. And so if you need intensive services, other than hospitalization, if you need in-home services for your child, you may not be able to get it, because not only won't you qualify for Medicaid, which is a huge problem, but it might be difficult to get. But as you can see, we have a range of programs from early childhood mental health consultation. A lot of people, their first stop is primary care with their pediatrician or family physician, outpatient therapy by a mental health professional, case management, respite care. Our in-home service is called Children's Therapeutic Services and Supports. We have virtual behavioral homes that really provide more intensive care coordination. We have youth assertive community treatment teams. If you can get on Medicaid and get the CADI waiver, you can get more in-home services. We do have mobile crisis and stabilization, although we don't do a great job in working with kids on that. Day treatment, partial hospitalization, therapeutic foster care, at least for the time being, residential treatment. You know, we did lose the federal Medicaid dollars. We have one psychiatric residential treatment facility and, of course, hospital level of care. I do want to mention the school-linked mental health grants, because this is actually providing therapy to kids in the schools. And it's really an important program and viewed as a national model. So the grants actually do not go to the schools. We do not expect schools to diagnose and treat kids' mental illness. But what we do want to do is eliminate barriers for families accessing care. Trips to the therapist. I mean, it's usually typically 20 weeks, and so I want you to imagine taking off of work 1 day a week, leaving your job, picking up your child, bringing them to the therapist, bring them back to school, bring them back. A lot of families just can't do that. They'll lose their job, and so kids don't get treatment. The mental health providers get the money then, they co-locate in the schools, working with the school support personnel. They can bill public and private insurance, so there's a little bit more sustainability there. And the grant money is used for kids who are uninsured or underinsured, and for services that you can't bill for example, working with teachers. The point of this is not just to diagnose and treat children, it's to build the capacity of the whole school to support kids who are struggling with their mental health. So if you have a first grader who's got school refusal because of severe anxiety, the mental health professional will work with that teacher to know how to support that kid in the classroom. The next child that comes in with an anxiety disorder, they're going to know what to do. When we did a bunch of interviews with families whose kids are in residential treatment, some of them said the number one reason was the school could not support their child who had serious mental illnesses in the school. What we found all these years, the program's been around 10 years, half of the kids never received treatment before, and half of those kids had a serious mental illness. So you know that they were not doing well in school. Again, it's important that they collaborate with the school support personnel. If you look at the PBIS triangle, some of you will know about that, we're really supporting the kids at the very top. The school support personnel are here, and the kind of multi-tiered strategies are kind of on the bottom of that. One important part for families in particular is because the money goes to the mental health providers and not to the school, we have a firewall between the mental health records and the school records, which families really want. In 2015, we served a little over 14,000 kids in 872 buildings. By 2017, we were over at 16,000. The new grant projections, which just came out in the fall, is we don't know the number of kids, but we were able to greatly increase the number of schools that we're in. The program costs about $11 million a year of grant money. We also have the grants to the intermediate districts. They're serving the kids who have the most complex mental health needs. That money was just awarded in 2018. 2 of the districts are working kind of within themselves, and 3 are working with mental health providers. And again, it's really trying to focus on kids who have the most complex needs. So we're really looking at embedding a mental health professional or practitioner within that classroom, because as those, kind of stressors of being a student come in, they can help that student. Lastly, I just want to say, here's the mental health workforce. We sometimes get confused, especially in education, about who's a mental health professional and who's a school support personnel. We've got psychiatric nurses, clinical social workers, psychologists, psychiatrists, marriage and family therapists, licensed professional clinical counselors. Many of the school support personnel who are very, very important, but many of them are actually not considered a mental health professional. They can't diagnose and treat, but again, they have a very important role to play, which you will hear about soon. The one thing that I want to say, though, is that you could give school-linked mental health 100% increase like you did in 2013, and we would not be able to carry out the program. We have a huge workforce shortage. These are just two maps for psychiatry and licensed social workers, and we have some counties that don't even have a licensed clinical social worker. And so we need to make sure that at the same time that we're putting money into these programs, that we're building our workforce so that we actually have people who can carry out the work. Finally, I'll just say that, all these many years, we've actually kind of learned what works. And we just need to make sure that they're accessible and fully funded so that all children can access those services. I do want to mention our big concern about the loss of federal Medicaid dollars for our children's residential programs. If we lose that level of service, we'll be sending lots of kids out of state, lots more kids out of state, which is not good for families.
Ms.
We do-
Abderholden, I just
Yes.
want to make sure that you're wrapping it up so we have some
Yes.
time for questions.
This is
Thank
the
you.
last slide.
Got it.
We need to enforce mental health parity. It is the law. And we need to make sure that families who have good insurance can actually obtain the care, and again, addressing the workforce issues. So sped through all of that. I know you have some handouts as well, but again, I just hope you get at least a little bit of an idea of how mental illness appears in kids and what our system looks like.
And Ms. Abderholden, your slide presentation has some great statistics in there. Is there a way to get that to us electronically so we could have it posted on the website?
Yes, and you do have it.
All right, thank you. And then, members, are there any questions? Representative Gruenhagen, I believe.
Oh, thank you, Madam Chair. Well, thank you, Sue. I've observed you a number of years, and you've done just a really good job of highlighting this issue down here at the Capitol, and thanks for all your work and the people who work with you. I do have a concern, though, and that's in the area of the labeling and drugging of children in our state. I'm a layperson, but from my research, like France labels and drugs only 0.5% of their K-12 education population of students. We label and drug between 9 and 11%. We just had a front page article in the Minneapolis Tribune, I think it was this summer or fall, that I caught. 10% of our school-age children have ADHD, and we know that that's the use of psychotropic drugs. I would encourage members to look into this. Another book I've read is co-authored by a former president of the APA. It's called Destructive Trends in Mental Health, The Well-Intentioned Path to Harm. And in there, he has a chapter saying the diseasing of America's children. So I think, why are other countries, I guess my question is, why are other countries labeling and drugging a much smaller percentage of their K-12 children than what we are? And the one thing I would add, I would encourage members to talk to military recruiters. If you use psychotropic drugs on developing children past 12 years old, they need a waiver to get into the military or they're declined. The reason is long-term use of psychotropic drugs on developing children past 12 years old creates a negative side effect of violent outbursts of uncontrollable rage. Well, you probably don't want that in the military. Now, the Army's loosened it a little bit, but the other military, and I just talked to a military recruiter this summer at a county fair, but I do think we have to try to take a more substantive issue on mental illness rather than the quick solution of just, here's a pill, and I hope you make it. Any thoughts on that?
Thank you, Representative Gruenhagen. Just a quick reminder, we only have a short time for questions, so if we could keep our comments a little brief and get to the questions quicker, that'd be great. Ms. Abderholden.
I could have talked for an hour, so I did cut my neck.
I understand that, Representative. Ms. Abderholden.
So I will just say that School Linked actually helps with that because you're really starting with the therapist first to see, and the earlier you intervene, the less likely it is perhaps that you will need medication. But I do want to say that in some situations, children really do need that medication, that it is so seriously disrupting their success in school, with friends and life at home, all of that, that they really do need it. But with ADHD, we also know that there are some kids who really do need that medication, and there's some who do not. And we want to make sure that we focus on those strategies so that they don't need it. But again, if it's your child who is threatening suicide, you're going to want them, frankly, to have an antidepressant so they can work with the therapist and get better.
Representative Hewitt, you had a question?
I did. Thank you, Madam Chair. Mrs. Abderholden, do you have any idea from your past on how many of these kids are showing up in the ER without insurance?
Chairs, Representative, I know when we looked at the school-linked mental health data that it was about 20%, only 20% had private insurance. With the ER data, I do not have that information, but just, kind of generally. We also know that it's true that for American Indian youth, they are less likely to be insured. That's the highest uninsured rate among children.
Thank you, Ms. Abderholden. Representative Moeller.
Thank you, Madam Chair, and Ms. Abderholden, thanks for being here today. So one of the things I'm told in my school district is that students will visit one of the mental health counselors in the school, and then after 3 or more times, their parents are notified so that they have a drop-off rate for students who are just going once or twice and then not continuing because they might not want their parents to find out. I didn't know if that was specific to my district or if there are rules around that and if anybody's tracking how many students are going maybe just once or twice and then not getting that continuous care.
Ms. Abderholden.
Yes, for the chairs of the committee, there is actually tracking through the school-linked mental health data about treatment completion rates, and it's actually much higher in the schools than it is in the community. Partly because, again, we're eliminating the barriers for parents to be able to do that. And most of the school-linked mental health grants actually started in elementary schools and not in high school, so they would actually have to get parental permission to diagnose and treat that child.
Thank you. I think I don't see any other questions, and I know we're going to move on, but I'm sure Ms. Abderholden will be available for questions for any members after the committee or by email. Thank you.
Absolutely, thank you.
And over to Chair Dabney.
Thank you, Chair Joachim. And we're going to be trading off back and forth on chairing the committee. Hopefully, folks will be able to track that. We now will have a panel on student school support personnel. You know who you are. If you would please come up to the stand, we'd appreciate that. This panel includes, and I'll ask the members of the panel to introduce themselves, but a school social worker, a school counselor, and a school nurse. So 3 of the key school support personnel who interact with students on a daily basis. We thought there's great value in understanding their experience and perspective. So I'm not sure who's going to go first, but whoever you are, again, please introduce yourself for the tape and then proceed with your testimony.
Thank you, Chairman Dabney. I'm Kelly Arrington. I am a school social worker in Minneapolis Public Schools. I think on the agenda it might actually say I'm a school counselor. I'm part of Minneapolis and the Minnesota School Social Work Association Board. I'm a licensed clinical social worker in Minneapolis on the north side. As we near the 1-year anniversary of the tragedy that occurred at Marjorie Stoneman Douglas High School, our nation has continued to engage in an essential dialogue and advocacy related to school safety and violence prevention. With each school shooting, safety is a top concern for our communities and those of us that work within a school setting. Violence, injury, and unaddressed student mental health concerns can create climates with the school setting that inhibit learning while adversely affecting the well-being of students and school personnel across the United States. As a result, we are faced with a public health issue that requires a balanced and comprehensive integrated approach that focuses on the physical and mental well-being of all individuals connected to the school community, including students, families, school personnel, and community members. Although there are many adults in our schools who provide mental health supports to students, school social workers are highly qualified mental health professionals who offer comprehensive approaches that specifically address the emotional, social, and academic needs of students. While the roles and responsibilities of school social workers may vary significantly from school to school or district to district based on the needs of the students, school social workers operate under a scope of practice dependent upon our education, training, and level of licensure. As school social workers and school nurses, we have a unique identity in that we receive 2 different sets of credentials, both a degree and a license. We're both mental health professionals as well as licensed educational professionals. Minnesota school social workers are duly licensed both by the Minnesota Board of Social Work and the Minnesota Professional Educators Licensing and Students Board. School social workers at the master's level receiving clinical supervision or holding the clinical licensure are prepared through their education, practicum, clinical supervision, and licensure to provide clinical mental health in the school setting, which constitutes about 3/4 of the school social workers employed in Minnesota. Licensed clinical social workers use their skills to address the mental health needs of students through evidence-informed assessment, intervention, evaluation of individuals, groups, families, and school-wide programming. We also serve as a resource to administrators and other educators, providing consultation and training on how to identify students with mental health needs and a referral process when services are sought. In times of crisis, school social workers are uniquely positioned to assist in crisis management and postvention, helping students, families, and staff process their pain and fears. At the same time, our expertise in navigating resources, both in the school and in the community, is pivotal in our recovery process. As mental health professionals, we understand that learning cannot occur when students, families, staff, and administrators are profoundly impacted by the crises of unmet mental health needs. In my last 6 months as a school social worker, I have supported staff as they've witnessed and became the first responders as a car fleeing police ran over children on a playground. I have guided teachers on how to connect with families as they attend the funeral for parents of their students who have been killed by violence in our community. I have comforted students as they make the tricky adjustment from living with a caretaker to a foster home. I have met with families as they make the choice to pursue mental health crisis support and determine if a day treatment program is what's best for their child. I've given a formal recorded statement to Minneapolis Police Department detectives due to the student's disclosure of sexual abuse by a family member. I've had the privilege to attend the graduation ceremony of a student who participated in a half-day treatment program for 15 months. I have facilitated student support team meetings, mental health team meetings. I've led staff-wide training on toxic stress and how it impacts learning. I've led staff-wide trainings on implicit bias to ensure culturally responsive teaching, and I've prepared reports for the Office of Civil Rights based on our behavior response data. Each one of these trainings, meetings, and teacher consults have resulted in an ongoing list of students who have needs beyond what can be supported by the classroom teacher alone. As we exist in an industry driven by ratios and formulas, it's scary to think that it has been said on paper that we need only one social worker for 600 students when I'm in a building with 420 students with 3 full-time social workers, and we go home every day with the burden of knowing what needs we weren't able to meet that day. With the ongoing strain of resources and funding, those of us who have the knowledge and training to support trauma-informed schools and programs are pushed into a reactive, crisis-serving model. We are equipped with the skills to support those urgently in need, but we miss the opportunity to practice in a preventative and proactive model. Administration has to decide if they invest in mental health supports or academic supports. Chairman Dabney and Chairwoman Yoakum, myself, along with Ms. Sweat and the rest of the school social workers in Minnesota, care deeply about our students and their future. We ask that you continue to support our efforts with students that we serve and all of the students that we wish we could serve if we were given all of the time and adequate funding.
Thank you very much. If the panel could continue, and then we'll hold questions until the panel has completed their testimony. So again, please decide amongst yourselves who's next, and then if you would please introduce yourself for the tape and then proceed. Thank you.
Sounds great. Chair Dabney, Chair Joachim, and members of the committee, thank you so much for the opportunity to testify today. My name is Trina Olson. I am a school counselor in the Milaca School District. I also serve on the Minnesota School Counselors Association Board. I've been a school counselor at Milaca High School for the past 12 years. I serve students in grades 7 through 12. Prior to that, I was an agriculture education teacher for 8 years. So I have some experience with teaching as well. At the outset, I would like to say that licensed school counselors, along with school social workers and our school nurses and all other student support members in the schools, play several different roles in the lives of supporting our students, or the lives of our students and in supporting them. Licensed school counselors are often the first point of contact for students who are struggling with academics, with figuring out their future plans, personal social growth, and their mental health. In an ideal world, our schools would be fully staffed, that we were able to provide for all of their needs collaboratively. Unfortunately, many schools struggle to achieve that full staffing. While we do our best to help students achieve their full potential with the resources we have, we know we're struggling. We often are shuffling students place to place just to provide the best we can for their needs on a daily basis. There are oftentimes we are also turning students away, and I'll talk about that later. In my school, we're fortunate. We do have 3 school counselors this year for the first time, and school nurses, as well as 1 school psychologist. However, we don't even have a school social worker in our high school. We also do not have any chemical dependency counselors. Today, I'm here specifically to talk about what my colleagues and I are seeing around the state in terms of mental health. We know the facts and statistics. We had a wonderful presentation to start this. We know 1 in 5 of our students have or will have a serious mental illness, and most of those start before age 14. We see evidence of student struggles all over. This past year, Milaca School District lost 2 students due to student suicide. There have been suicides throughout the state, unfortunately, also the horrific school shootings. We see schools around the state stepping up to do what they can with limited resources to try to meet student needs. Our school, in a year of budget cuts, was able to add an additional school counselor because we knew that was such a need. Whether we can continue that long term, I don't know. The metro area, Hopkins High Schools, and 2 of their junior highs are adding new mental health centers to meet student needs after school. We know our students are struggling. In our experience, we had students coming to us saying, we need to see you, we need to meet with you, and we can't. Our friends are hurting, our friends are struggling, and they can't get an appointment. So we chose to keep data. The month of September 2017, we kept data on who wanted to see us and who couldn't. In just Milaca High School alone, we turned away 9 students on average every single day. That's 1 little high school, 9 kids every day that we sent home not knowing what they needed, not knowing why they came to us. For all we knew, those kids had finally reached the point where they were ready to reach out and get the help they needed to the people they've been told they can access when they're facing these challenges. And then to be turned away because we don't have the staffing, I can't imagine what that's doing long-term, to our students. You finally are at the point where you're ready and there's no one there because there's not the help. We know our students are struggling. And there's a lot of attention being paid to the mental health issue. As mentioned before, schools are stepping up as much as they can on limited resources. Counties are stepping up their mobile crisis teams. The state has stepped up its school-linked mental health grants, and that's been helpful. However, as mentioned before, most students require parent permission to meet with a school-linked mental health professional. As we know, sometimes that's very difficult to obtain. The state also has funded the Metro Pilot Program for the single crisis phone number. These things are all a part of the solution. As I think my other mental health partners up here will tell you, access is critical to ensuring student overall success. Mental health indicators for our students can occur at any time. In the classroom, in my office, in your office, in your office, in the community. Because of the complexity and pervasive nature of this problem, school counselors and other school staff really see a solution in making sure that our schools and communities are fully staffed with professionals that can meet students where they are at today. I will tell you that licensed school counselors are an incredibly important part to helping our students and that our schools need more of us. I will also tell you we need more school nurses, we need more school social workers, we need more school-linked mental health providers. And we can't protect from everything, as was said before, but we can certainly provide access to support services when those things happen. The average school counselor caseload in Minnesota is currently around 750 students per counselor, about 3 times higher than the levels recommended by the American School Counselor Association. I know my partners up here have similarly dismal caseloads. Unfortunately, Minnesota lags woefully behind in our investments in student support services. We recognize funding isn't always the answer, but sometimes it is. And in this case, getting kids access to the mental health support they need, ensuring them access to licensed professionals who are ready to help them on their journey to academic, professional, and civic success is something I feel is well worth putting funding towards. Thank you for all the state has done. Thank you for starting this conversation about what we can do together to help keep our kids safe and successful. Thank you very much for your time, and we'll answer questions at the end.
Thank you, Ms. Olson. I'm hoping you're Ms. Holland.
Yes, I am.
Excellent.
And thank you, committee chairs and committee members, for allowing me this opportunity to testify before you regarding children's mental health. My name is Jolie Holland, and I'm the legislative chairperson for the School Nurse Organization of Minnesota, otherwise known as SNOM. This is a professional organization for licensed school nurses in Minnesota. We're also known as LSNs. And LSNs collaborate with social workers, counselors, psychologists, teachers, administrators, families, and students to provide health care for students, including mental health. We are the only healthcare providers trained and licensed in the school setting that are able to assess, plan, and intervene for students' physical and mental health care needs. And I'm going to suggest that today is very timely, as one of the members of SNOM that's here today had 2 of her students admitted just this morning to a mental health unit, to a hospital, and due to mental health conditions, and 2 school nurses were involved. Licensed school nurses are often the very first to recognize psychosomatic symptoms of students. Now, psychosomatic symptoms are physical symptoms that arise from mental health conditions. So often we'll see students coming in our health offices with headaches, stomach aches, they're tearful, they're tired, they're avoiding classes, they might act out and have behaviors. They might be self-injuring. They might be complaining or stating that they're suicidal. Or they just say, I don't feel good. And what I do when these students come in is I assess, and I try to figure out, is this a physical condition or is this something mental health? And I work with the parents to try to determine if we can rule out a physical cause, and then we'll look at if there's some mental health needs and get them referred to where they should go. So do our children have access to LSNs? Well, Minnesota passed a law about 30 years ago. And what it does is it requires districts to have 1 LSN per 1,000 students. So if you have 999 students, you're not required to have an LSN. And if you have 20,000 students, you're still only required to have 1 LSN. A recent survey completed in Dakota County identified many schools with LSNs. However, when they looked deeper, the LSNs had to cover multiple schools, leaving a non-nurse in the office for a majority of the school day. And many people who, like parents, believe that there is a nurse in the health office. Well, this is often not the case. How does a non-professional respond to a crisis? How can they expect it to be adequately support the needs of the students, especially mental health student issues? Will the students simply be sent back to class? Without an LSN, students go home more frequently, ambulances are called, and serious conditions such as diabetes, asthma, anxiety, and depression are often not managed. Our districts do the best they can to meet the healthcare needs, and my school district tries very hard. However, I'm the only LSN for my school district and a special education cooperative, and I have 16 schools in 12 locations that I'm responsible for with over 1,600 students. I often go to 2 or 3 schools a day, and when an emergency arises, I have to drop everything and go to that school. When I'm not in the office, we've got health aides, secretaries, and principals who are responsible for making decisions to support the children's health. Now, this varies throughout the state, but in particular, the rural students and schools lack professional nursing support. I'm familiar with a district whose nurse quit due to her concern regarding her nursing license and the heavy load she was asked to carry. And I'm also aware of a school that represents they've got a school nurse when actually that nurse is only there 1 day a week, sometimes 2. Care coordination provided by LSNs helps students with mental health issues, asthma, diabetes, severe allergies, and seizures remain in school and able to learn. And many times, I have students in my office that may be on 4 or 5 different medications for mental health, and I can help assess and find serious health side effects, and I have found many serious side effects that students are experiencing that were not caught by the families or the healthcare provider. So we feel that 2 problems should be addressed. One thing is that the complex care of our students is much more significant than it was 30 years ago when this law was passed. And we're so thankful for medical advancements, but many students are in school now that did not survive 30 years ago. So that law is outdated for what we need now. And secondly, we believe that we need data to help determine policy. There is no statewide requirements for health conditions to be reported in schools, such as ambulance calls, suicide attempts, asthma attacks, anaphylactic reactions, mental health hospitalizations. There's no data required. Health education policies, what we're concerned about is whether educational health policies and decisions are made based on data or response to crisis. Did you know there's no reporting regarding the credentials of those providing health care to our students? And parents have a right to know who is providing care for their children and what their qualifications are. Parents and students have a right to quality health service in every school. We believe that data collection and analysis is crucial for the development of policy for health and mental health. LSNs are passionate about the physical and mental health needs of our students, and we know that healthy students are better learners and are more successful in the classroom. So the School Nurse Organization of Minnesota looks forward to partnering with you on creating policy that will improve the mental and physical health of our students. Thank you.
Thank you, Ms. Holland. And to members' questions, as Chair Joachim had indicated, if you can focus on the question part of the question, that would be helpful. Thank you. Representative Erdahl.
Thank you, Mr. Chairman, and I'm all about questions, so. Just to the testifiers, I guess, in general, you know, I want to, allow that, certainly I'm concerned about the state of mental health in our education system. And when I've expressed in the past about the lack of counselors and the low rating nationally that we have in Minnesota, some folks will say to me, yes, but we have all kinds of school social workers. And so, to help clarify a little bit, knowing that our counselors, besides meeting mental health needs, also have the academic and career counseling portion of their job. Could you help to clarify the different roles between the social worker and the counselor?
Yes.
Ms. Olson, is that you?
Yeah, well,
Thank you.
I can start.
Certainly.
Representative, at my school district, we do not have a school social worker at the high school. However, at the elementary school, we do not have school counselors. So it's very interesting. So in Milaca, at the elementary school, one of our school social workers actually is a licensed school counselor, and so she's very much doing the work of both. At the high school, one of our school counselors is a licensed school social worker, and so she is very much doing the work of both, because we're doing, well, not to its full extent, but we're doing the best we can with what we have. If we were able, ideally, to have both, then definitely there would be a way to work that out. But probably school counselors have more of a focus on the academic career, keeping track of credits, the schedule, those types of things, which have to happen for the goings-on of a school, where school social workers are more uniquely positioned to focus on families and the supports in the community and groups and those kinds of things that often school counselors don't have time for. Thank you.
Thank you. Ms. Arrington.
Yeah, chairs and rep, yes, and, right? It is really complicated because I think at a surface level vision, it looks like we're doing similar because we are such a collaborative system. But like my colleague said, we as social workers are licensed clinical practitioners. Most of us, I had said 3/4 of, some of the greater Minnesota, it's harder to pull on that licensure. But we have a systemic system where we see families, communities, schools, teachers. And so when we are supporting a student, yes, we're considering academics, but we're looking at what are all of those toxic stress factors that are barriers to them being learners, supporting those so they can then access the academics, which then the counselors would help support. You know, there was a question about the increase of mental health and why that's maybe present. As the stressors external, outside of schools seem to grow, that's where I think a lot of that mental health comes in. And so we have, as social workers, the understanding of how housing plays into like the limitations of our medical models, to the limitations of transportation, to the limitations of, and sort of assess all of them at the same time.
Representative Erdahl, a brief follow-up?
Very brief. So maybe, I don't know if you guys know the answer or someone else, but is there a requirement in state law in Minnesota that a school district has to have either a counselor or social worker or both?
Does anyone know?
Chairs and reps.
Ms. Arrington.
I don't think that there's recommendations from the national boards of each profession of what the ratio should be. There is not a formal mandate that districts have one or the other. All they have is the more informal recommendations from the licensing boards.
Thank you. Representative Murphy.
Thank you, Mr. Chair. I have two questions. Ms. Olson, do the counselors do help with the testing?
Representative Murphy, in my...
Ms. Olson.
Oh, I'm sorry. Representative Murphy, in my district, we do not help with the testing. There is a specific testing coordinator, yeah. But in several districts, they do.
Representative
Still,
Murphy.
still, Mr. Chair. Ms. Holland, tell us more about who would you be collecting the data from, or who would be providing the data?
Ms. Holland.
Thank you. Well, we would be looking at having the school nurses that are in the school districts. Most of us have electronic medical records that we could pull reports from and start gathering some of that data. And school counselors, I'm sure, would help with that, too.
Representative Murphy.
Based on the kids, the data that comes from the kids in your system?
Correct.
Ms.
But
Holland.
not the state as a whole?
Well,
Ms. Holland?
thank you. What we would be doing is pulling that information together and putting it, correlating it so that we could report it to the legislature and Minnesota Department of Education, the school nurse organization.
Representative Murphy.
Mr. Chair, Ms. Holland, does the health department not do that already?
No, they don't.
Ms. Holland.
I wonder how that slipped by, Mr. Chair. Thank you.
Thank you. Representative Christensen.
Thank you, Mr. Chair, and thank you, panel. Awesome information. Could you just do a quick rundown, if you have it on the top of your head, what is the recommended ratio, student to professional ratio for an LSN, for a mental health worker, and for a counselor?
Okay, this is the speed round.
Yeah. Chair and board, we, as the National Board for Social Work, recommend 250 to 1.
Okay.
Ms. Olson.
Chair and board, as Trina Olson, I recommend 5 to 1. Just kidding. The American School Counselor Association recommends 250 students to each school counselor.
All right. Ms. Holland.
Well, we're still working in progress with that, trying to determine, because the old law said 1 school nurse per 1,000 students, but we feel that that is way too, and if you, like we said before, if you have 20,000 students, you still just need 1 LSN. So we feel like we need to look at the numbers and reassess it in today's light, not 30 years ago.
Thank you all. We've got 2 representatives with questions. If you could both please be brief. Representative Abderholden.
Hi, thank you. As a social worker, I really appreciate the panel here and being a parent with children in the public schools. It's a concern. I believe the school counselor had said 9 kids every day that couldn't, that you were not being able to help. I'm really curious about the operations of that, and I'll be very brief. Can you tell me what was the follow-up to those students that you had to turn away?
Ms. Olson.
Thank you. Representative, there were 2 school counselors at the time this happened. We were not eating lunch. We were doing everything in our power to see as many students during the course of the school day as we possibly could, and that still resulted in the 9 each day. The next day then, we're trying to gather up those students from before. Now, it was an average of 9, I should say. So some days there were fewer, some days there were more. But what happened is the problem just prolonged. So that was September, the first month of school, it was that many. If we were to have been able to keep data all year long, it would have been way worse by the time we got to December.
Representative Edelson.
So just to be clear, I just want to make sure that the room understands what we're saying here. So there's kids that are falling through the cracks, is what you're saying,
Ms.
that are
Olson?
not getting help?
Representative, that is correct. In 2016, I kept data, also just my half of the alphabet. We split the alphabet in half. This is off the top of my head. I can get you the actual numbers if you want, but it's just Milaca High School. School year ended, the end of the year came. I had over 50 students that had wanted to see me that I never connected with.
Thank you.
Thank you. Representative Scott, last question for the panel?
Thank you, Mr. Chair. And this question would be for Ms. Holland. And you mentioned that you have access to medical records of these students. And I just wondered, is there a database that you use, or are you getting parental permission to get access to their medical records, or what does that look like?
Ms. Holland.
Thank you. Let me clarify that. I have a program that I use called Synergy, that when a student comes in my health office, I can document the data. We don't have access to the student's health record unless the parent would give us access to that through a release of information that they have to sign.
Thank you.
Representative Scott?
Clarification. Thank you.
All right. Representative Joachim.
Thank you.
Thank you to the panel very much.
Thank you, Chair Dabney. Yes, next up is Education Minnesota. They have some folks here that have been working in the schools that would like to present us with some more information. Could you please come forward and introduce yourselves and state your name and title for the record? I'll let you decide who's going to go first. And this will give us a little bit better snapshot of the kids in our schools and how they interact with our teachers.
Hi, my name's Casey Cavanaugh, and I teach first grade in St. Paul Public Schools.
My name is Justin Killian, and I work in the Policy Department at Education Minnesota.
My name is Jill Russell, and I'm actually a school social worker as well, but in early childhood programming, and I have been in the classroom in the past.
Thank you. Go ahead and proceed.
Thank you, chairs. It's a pleasure for us to be here today. Again, my name is Dr. Justin Killian, and I work with the Educator Policy Innovation Center at Education Minnesota. Student mental health concerns is one of the most primary issues that is concerning the members of Education Minnesota, and it is the most consistent worry, those of us working in the policy department here, when we're out in the field talking to our members. So let me be direct. We thank the organizations before us for their testimony and setting up some nice statistics, and we would like to add, number one, state policymakers must address this crisis now if they are interested in closing the opportunity gap and dismantling the school-to-prison pipeline. Number two, this is a crisis facing all corners of the state. Rich, poor, rural, or urban, it might manifest different in different places, but all students and all educators are facing this issue. And finally, this crisis directly connects to the school-to-prison pipeline and the racial discipline gap, and the lack of mental health interventions has caused an increased use of punitive disciplinary measures to address behaviors that are merely manifestations of traumatic life experiences. Unfortunately, students of color receive a disproportionate number of these interventions. Our previous EPIC research teams have addressed these concerns in several papers. We've been a leading voice for full-service community schools, which embeds mental health services within the school community. We've been a strong advocate for universal pre-K, which requires the hiring of licensed professional teachers who can help flag health concerns at early ages and help students seek early interventions. Most recently, we've pushed this body in the Senate to provide funding to build trauma-informed restorative schools that are rooted in making educators aware of adverse childhood experiences. And we will soon release new data about how schools need more student support services to help fight the mental health crisis. Today, I would like to add two more things to this conversation. First, the mental health crisis in Minnesota is linked to ACE scores and the school-to-prison pipeline. All states in the United States conduct a survey of the prevalence of adverse childhood experiences in their population, and each state has the right to select its own categories. When our Department of Health conducted the study here in Minnesota, we had 9 categories: physical abuse, sexual abuse, emotional abuse, mental illness of a household member, problematic drinking of a household member, illegal street drug use by a household member, divorce or separation, domestic violence towards a parent, and the incarceration of a family member. So when you take the ACE survey, you receive 1 point for each category that you've experienced, and we know that 55% of us walk around with at least one. Also, Minnesota Student Survey, conducted in 2013, looked at public school students and only asked them about 7 of these categories. 8% of the student population in Minnesota scored 4 or higher. We know that in an average classroom of 30 students, 2 to 3 students have an ACE score of 5 or higher, and in some level 4 settings, there's not a single student with an ACE score of 0. Why does this matter, you might ask? People with 4 or more ACEs are 12 times more likely to attempt suicide, 5 times more likely to be beaten or raped, 10 times more likely to inject street drugs, 7 times more likely to be an alcoholic, 2 times more likely to have cancer, and 2 times more likely to have heart disease. Medical doctors and mental health professionals have confirmed to us that students with high ACE scores have physically different brains, and they respond to stimuli and triggers with fight, flight, or freeze reactions often beyond their control. Unfortunately, rather than hiring more counselors to help educators unpack this trauma, we have invested in and responded with punitive measures that have increased the use of suspensions and expulsions. The second thing that I would like to stress is that the student mental health crisis in this state is also an important equity issue. The student discipline reports put out by our Department of Education show the use of exclusionary interventions are going up, and these measures increase student connections to the criminal justice system. We know that students with higher ACE scores will respond to stimuli differently, and we know that students of color disproportionately have higher ACE scores than other students. Unfortunately, implicit bias has led to an equity gap in the use of exclusionary practices, and we know that American Indian students were 10 times more likely to be suspended than their white peers. African American students were 8 times more likely, and students of color and students with disabilities were twice as likely than their white peers to receive a suspension or an expulsion. However, this is very important. There is no social scientific proof that these demographic categories of students are misbehaving at any higher rates than their white peers. Research does show that these groups experience more trauma, and what happens is we're offering them more punitive interventions and not mental health support, and this is leading to a cycle creating more problems and offering little in preventative solutions. So we would like to see the state move in the direction of hiring more mental health workers, hiring more education support professionals, and training them to work with students facing mental health issues, stopping the use of exclusionary interventions, especially with our young elementary students, follow the recommendations of the Student Discipline Task Force created by this body, which said that the Minnesota Department of Education should offer training for all school staff on mental health and trauma-informed schools, promote trauma-informed restorative schools, and reduce class sizes so teachers can do their job and create relationships.
Thank you, Mr. Killian. Having gone through ACES training as a para, those statistics are very depressing but very informative when it comes to working with kids, so thank you. Who would like to go next?
I'll go next. Chairs.
Thank you, Mr. Cavanaugh.
Thank you. Hello, my name's Casey Cavanaugh. I've taught first grade in St. Paul Public Schools for 25 years. Soy maestro en la escuela de inmersión. When a server goes into the kitchen and tells the chef that the mashed potatoes are cold on a lot of plates, changes are made. Today, I am your server. You are the chef. I am hoping that you make changes. I want you to hear what happens in classrooms so that you can make well-informed decisions about how you're going to help the children of Minnesota. As soon as my students enter the room, it's crisis after crisis, problem after problem. Then it is my job to teach them. I have seen students throwing chairs across the room. I have seen first graders that can't spell their name. I have seen students jabbing other students with pencils and scissors. I have seen students bullying other students numerous times. I hear students swearing and using filthy language towards other teachers, towards other students, and towards teachers. I see students running down the hallways, tearing things off the wall. I have students in my class yelling while I teach. I have seen students cowering when they need to go into the hall to get something out of their locker or use the bathroom. I would like to tell you that I have 27 students in my class, 27 6- and 7-year-olds. Stop for a second and think about that. 28 of them. Students with mental health issues consume my day. I have to tend to their needs immediately, thus ignoring all other students. I stop being a teacher and I resort to a survival mode to protect everybody and offer the good of all students. I once had a student that would throw chairs daily. He would knock the books off the shelves. He would throw math manipulatives all over the place. He'd tear things all off the wall, knock the garbage can over. All the other students tried to hide behind me or would just run to the other side of the room. We'd go to the hallway and wait for help to arrive. The situation has been getting worse and worse each year. I'm hoping that our state legislator can help. You control the policy function and you control the appropriations. Schools need more counselors, therapists, psychiatrists, TAs, and smaller class sizes. These professionals step in and help the child calm down, refocus, and get back into a learning mode. Teachers can do this with 1 or 2 students, but when there are multiple students in the classroom causing distraction, learning for all students stops and suffers. I've had to stop teaching my class for hours so I could tend to one student who was a threat to all. Hours. I need help, teachers need help. And while there may not be enough federal policies or monies earmarked for helping out our schools, I would like to see Minnesota citizens and the legislator step up to the plate and be a leader. Mental health problems develop in early childhood. They are treatable. Early detection and interventions work. Teachers are frustrated. Parents are frustrated. Thus, we must assume that the students are frustrated as well. Thank you.
Thank you, Mr. Cavanaugh. And I guess that leaves Ms. Russell next.
Yes. Chair Joachim, Chair Dabney, members of the committee, hello, and thank you very much for having me here. I have been a social worker for the past 5 years, and prior to that, I was a mental health provider for 3 years. And I also was a classroom teacher for 8 years. So I have a lot of experience in a variety of ways in this subject we're talking about today. But I am here today because my colleagues and I see children, families, and teachers struggling to function due to a mental health crisis in our schools. For many students and parents, the school is the first resource for the family when they're grappling with a mental health concern. The school often sees mental health issues manifest as aggressive behaviors, withdrawing behaviors, changes in the performance of students in their school, and changes in their attendance patterns. Students look to the school for emotional support by creating relationships with teachers, school social workers, school psychologists, and counselors, but the needs often go beyond what those relationships can provide. Children who come to school with unmet social emotional needs cannot learn any more than a child who comes to school hungry or tired. Currently, I work as a school social worker for Robbinsdale area schools in the early childhood programming. One concerning fact that I learned when I started in this role 5 years ago was that preschool programs across the United States are suspending their children are 3 times as likely to suspend their students than students in other grades. When I heard that statistic, it really choked me up 5 years ago, and it still does today, obviously. A 2016 national survey of children's health by the Center of American Progress found that 50,000 preschoolers were suspended at least once, and 17,000 preschoolers were expelled. Statewide, public preschool programming has been attempting to do a better job with social emotional learning by adopting pyramid model practices to teach behavior expectations but many children need more. Aggressive behaviors, inconsolable crying, social withdrawal, and bolting from the classroom are commonly seen in our students that need more than what our teachers have to offer. These extreme behaviors are truly mental health issues for our young children. Another way in which an increase in mental health disorders is exemplified in our early childhood program is through our special education referrals. I am a part of our special education assessment team, and we are seeing a steady increase in children who are referred for evaluation simply because of behavioral concerns, which to us means mental health. Children are being expelled from their private preschools and sent to the public preschool or to our assessment teams, where we are thought to have more resources to address the social emotional needs of these struggling learners. But without more funding, we do not have the resources to adequately meet the ever-growing needs for the mental health support. Over the past 2 weeks, the Robbinsdale Federation of Teachers sent out a needs assessment survey to its members. 380 teachers, paraprofessionals, nurses, and counselors took this survey. 80% of the respondents indicated unmet mental health needs in our students as highly impacting their academic success, and 15% said it was a moderate impact. Additionally, 80% of respondents felt that greater access to mental health services was very needed, exceeding the answer of smaller class sizes. Imagine, we have come to a point where teachers would rather the kids have more access to mental health than see a smaller class size. I think they need both. Teachers were asked which professional development topics were most essential, and the top 3 chosen were all related to mental health. The number 1 choice being the effects of trauma and toxic stress on our learners. To me, the response to the professional development is the most interesting. Teachers do not believe the legislature will fund schools enough to lower class sizes. They know we are nearly last in the ratio of student to counselor, so they're taking it into their own hands because they believe that they will get neither smaller class sizes nor counselors. So they look to professional development. Sure, this will cost a lot of money, but not doing it will cost more. We will have more special education referrals. We will have more kids expelled. We will have more kids not attend school and not graduate. We will have more teachers quitting. Please, give our children the mental health access they deserve. Thank you.
Thank you. Representative Wozlawik.
Thank you, Madam Chair, and thank you to the panelists. I work in a school-based childcare program, and I can tell you that a lot of those stories about chair throwing and other things also happen in our program. And I'm particularly interested in kind of the 0 to 5 age group, so I'm wondering if maybe each of you could share a brief thing the top thing that you think would help, particularly with the early childhood, that you think that we could do as a legislature to help kind of solve some of these issues.
Thank you. Think of this as a speed round, so a few words each.
Madam Chair, Board. 0, from what I've learned, 0 to 3 is the most important time, as well as great prenatal care. When a baby is born, why not give it a box of books, support to the family, everything that way. If a child is taken care of from 0 to 3, and then it goes on to maybe some trauma in its life, I know that in its heart there's love, and I can teach them a lot more easily, and it's my opinion.
I'd like to see more access to early childhood programming for all students. Because if we can get to know the families at an earlier time, we have a better opportunity to help them access additional services that they might need within the state, and or at least develop that relationship, because relationship is really important to supporting mental health.
Thank you. Representative Sandell?
Madam Chair, members of the panel, thanks very much for your testimony today and for your work on these issues. You and each of the people who have testified today have spoken about the situation that young children and children into their teenagers, into their teenage years face, but it seems to me that many of those issues begin with very young families. Mr. Killian talked about your support for community schools, and I wonder if you can tell me a little bit about the way community schools deal with the health of young families and how it's been successful in its limited experience, and what kind of additional costs you might be thinking about as community schools develop and grow.
Dr. Killian, briefly, please.
Yeah, so a quick answer to that is I would direct you to our website, or we can send it over a paper that explains the benefits of full-service community schools to you. But essentially, just as in a two-sentence answer, there's a full needs assessment done for the community, and then there's wraparound services within the school, medical clinics, mental health clinics, eye care clinics, and so the school becomes kind of a community hub that helps both the family and the child receive the services that they need. It's my understanding, the last time I looked at the numbers, but I would have to check this, that the request for schools to move to full-service community schools is not a tremendous leap for the state to make, the ones that are interested in doing it. But the ones that we currently have in operation are producing tremendous results for their community and are doing great work and have seen leaps and bounds growth, particularly related to mental health. So without having all the numbers in front of me, I would just say, yes, they're good.
Thank you. Representative Baker?
Thank you, Madam Chair. I guess, first of all, Mr. Cavanaugh, thank you for teaching. I recently was able to shadow a couple of principals about a month or two ago during National Principal Week, and one of them was an elementary school, and I was experiencing firsthand a third grader doing what you experienced in the first grade, and this third grader is 120 pounds and very strong, and I saw firsthand what's happening. And again, Ms. Russell, and again, I thank everybody for doing what they're doing. The classrooms are not what you think they are if you haven't been there. And I want to just maybe encourage my members, if you get a chance to do that. I know Representative Erdahl has been in the classroom personally, and he knows that many of you have as well, Representative Bennett. But I learned so much. My question today is focusing on mental health and social support. We don't have the bodies to give you what you need. Even if we had the money, the bodies are not out there in Minnesota that are licensed, ready to go, that I can see. I'm hearing that from our administrators. But my question maybe to Ms. Russell, how much support do you get, your administrative support? I heard from the gal from Milaca who says she didn't see 50 students. That is alarming, and I'm wondering, as we do here in the state legislature, we have administrative support so we can see a lot of people very efficiently. Do you have that kind of support system in the school system that we can ramp up more quickly for you, and so that you can actually touch more students the way you need to, visit with them? Do you have the support you have? Do you have the support you need today administratively?
Ms. Russell, I think probably
Sorry
that
for
goes
the
to
long
you.
one.
If you mean like someone to coordinate like my meetings and things like that, is that what you mean by administrative support?
Representative Baker?
Madam Chair, somewhat, but also that can sort of help out with a lot of deflection and filtering to you, so they can help
No.
a student part way too, just to kind of get that. So that's what I'm wondering.
No, that doesn't exist.
Okay,
Thank you.
thank you.
Representative Jurgens?
Thank you, Madam Chair. Mr. Cavanaugh, I want to thank you for the vivid portrait that you described to us, and I have no doubt that over your 25 years of teaching, you've seen many changes in the classroom and with the behavior of the students. And you indicated that the mental health issue is increasing. Based on your experience, can you help us why? Why is there that change? Why is there that increase in mental health needs?
Thank you, Representative Jurgens. I just want to remind folks, we only have about a few more minutes left for this, and I have quite a few quite a few questions on the list. And I do want to make sure PrairieCare is here to talk to us about what they're doing in the schools. So quickly, very quickly, please.
Madam, I have my own opinions, but I don't think I'm allowed to voice them. Anywhere from the food that children eat to the amount of screen time, and there's a bunch of stuff in between there. And what can we do about it in first grade? I don't really know, because the changes have just keep coming year after year after year. So I would like to have more professionals come in and help me find those things out. I can't answer those. They talk about special ed. I don't know what special ed is. I have to call in professionals and say, take a look at this, take a look at that. So I really need help. I don't know what to do. So I just refer to people.
Thank you, Mr. Cavanaugh. And we will be probably having a whole hearing on special ed and talking maybe a little bit more about ACES training. So maybe we can get some more answers then. And Representative Scott.
Thank you, Madam Chair. And I just had a question. I don't think ACES includes divorce or separation in the family, does it? Or does it? It is one of the factors, okay. And do you see that is that probably the most common of the ACEs, that a child sitting in a classroom that might have other ACEs on top of that? Is that kind of the beginning point, or not necessarily? Is there any data on that, do you know?
Is that to me? There is data on that. I'd have to go look, but no, I don't think it's the most common, actually. I think alcohol, witnessing a parent or guardian use alcohol is the highest, but I don't want to say that for sure. I'd have to go back to the actual data. But there is data that shows which ones are the most prevalent, and then when you have one or higher, and you're in that category, which ones are most prevalent for that 55% of the people as well, so.
And my point with that, Madam Chair, is just that even before they get to you, if there's been a breakup of the family, that already gets the kids out, a lot of times not out on equal footing with some of their peers that come from intact homes. And to the extent that we can work on keeping the families intact, I think it's going to help all of your jobs, hopefully a little bit more. But that's the million, the multi-billion-dollar question is how to do that. But thank you.
Thank you. I hate to do this. I know there's 2 more people, but we really have to move on to hear the rest of the testimony. Maybe folks can stick around afterwards and get their questions answered offline. Chair Daphne.
Thank you, Chair Joachim. Dr. Wall, if you would please come forward. We asked PrairieCare to be here to provide a provider's perspective. And Dr. Wall is a child psychiatrist who is joining us. Sir, if you'd please introduce yourself for the record and proceed with your testimony. Thank you.
Good afternoon, Madam Chair and Mr. Chairman, as well as members of the committee. It's an honor to present today, and it's a privilege to hear the other testimony today, because I think we're all in the same boat. My name is Dr. Christopher Wall, and I'm a board-certified child, adolescent, and adult psychiatrist. After medical school in North Dakota, I spent 14 years at Mayo Clinic as a resident, fellow, and then staff member, where I was a clinician, a researcher, and educator. One of the components of my work at Mayo Clinic and now at PrairieCare is helping to educate our teams, as well as those that come to us as students, to think about mental health care as treating a whole person in a biopsychosocial way, and also in a way that is very special to this field. We get to work with what makes us human, and the suffering is unique and extremely personal. I'd like to talk a little bit about some of my experiences in the field and advocate for increased support for our schools and communities so that they can best help identify, manage, and connect kids and their families with the care that they truly need. PrairieCare is currently Minnesota's largest provider of mental health services to children and adolescents. We have a 71-bed hospital for children and adolescents with psychiatric needs in Brooklyn Park. And we also have outpatient services available in Woodbury, Maplewood, Edina, Chaska, Brooklyn Park, Minneapolis, Rochester, and now Mankato. Last year, As an organization, we served nearly 15,000 individuals throughout the state. At present, there are fewer than 85 practicing child and adolescent psychiatrists in the state of Minnesota. Clearly not enough to treat even those with the most severe and life-threatening mental health concerns. According to national standards, every county in Minnesota, except for Olmsted County, is either severely or critically short of child and adolescent psychiatric care. So access to care within the Twin Cities as well as rural Minnesota is a major problem. This results in challenges once they do reach our level of care as we try to coordinate services and we struggle to find care providers within the communities to help out with the social and biological concerns that have been identified within our programs. When these impediments become clear, there's a major toll on our kids, the families, adults, social systems, school systems, workplaces, and more. Our mental health system is not broken because I believe it's yet to be fully built. More kids than ever are in need of mental health support, and our schools are on the front lines. We know this through experience, both by observation as well as measurement. We see more kids referred to our acute psychiatric services than ever, and the referrals are happening for even younger children with conditions that are becoming far more complicated. While we try to treat kids in our acute care programs, primarily in our inpatient and partial hospitalization programs, we're hearing more stories about bullying, aggression, truancy, sexual and physical trauma, and more. Usually by the time a youth ends up in one of our programs, they've already experienced traumatic symptoms that could have been alleviated earlier by identification and then access to the resources needed. Schools want to help, but I believe they're becoming paralyzed. While it is excruciating to know that there are so many kids identified with mental health needs that have not yet been connected to appropriate care, there are many kids who are still flying under the radar. These are the kids who are at the greatest risk and actually may be suffering the most. Past studies have shown that 50% of teens who made a suicide attempt were not known by school personnel to even have an emotional problem, and they were not receiving any type of care. While the strong infrastructure and curriculums within our Minnesota schools have made positive learning environments, this can only be done when students are actually ready to learn. As the testimony discussed today, chairs being thrown across the room really get in the way of learning fourth grade math. Students suffering from depression, severe anxiety, or even more serious mental illnesses are not going to excel in school. We have not equipped our schools to serve students with these mental health needs. Kids meeting special education criteria for EBD, OHI, and ASD are increasing, and schools are seemingly expected to become mental health professionals. Too often, kids with mental illnesses receive these special education services that can help accommodate with some symptoms, but this is not a replacement for clinical evaluation and treatment. We do not have enough school counselors, school social workers, or school psychologists to meet our present needs. While they play a critical role in identification of problems and referrals to care, there are archaic processes and fallacies that get in the way and discourage school staff from suggesting that a student seek mental health support. Many schools believe that if they make that referral, they are then responsible for either providing or paying for that care, and this just isn't true. While many barriers exist, we have had many amazing successes in our partnerships with schools, ranging from co-managing treatment, training school personnel, research studies, and actually providing integrated psychiatry within the school setting. We've also successfully piloted mental health screening programs to help identify those kids with symptoms of mental illness that are flying under the radar. And I would direct folks to the white papers that are in the hallway. And the author of these papers is one of PrairieCare's early proponents, Todd Archbold, in the yellow tie over there, if you have questions about some of the successes and challenges that he's identified through this research. These experiences have shown us that our schools are well-positioned to be more effective in identifying and connecting kids with mental health care. However, we need to provide them the tools to do so. We've seen gains in the schools that we have partnered with, but there are hundreds of other school districts with similar needs. As a psychiatrist and on behalf of PrairieCare, we feel that if the schools had the ability to better identify mental illnesses through screening and more open discussions, then many of our kids and families would avoid the suffering, despair, and cost of unidentified and untreated mental illnesses that we know exist today. And earlier I referenced the term biopsychosocial treatment. And what biopsychosocial essentially means is biological, psychological, and social. If we miss on any of those three components in care, I think we miss really helping facilitate true growth and improvement. So biology would work like you would expect, thinking about the brain as a complex chemical and electrical organ, and this is where genetics, substances of use, and medication regimens are in the realm of a psychiatrist's expertise. Even so, child and adolescent psychiatrists who are experts in this field are only prescribing less than 1 in 5 of the psychotropics around the country. Most are being provided by pediatricians and family physicians. Psychology defines a person's temperament and their response to stress. This is an area that can be thought of as both learned as well as trainable via therapy, and it is extremely important in the link, or in the chain. And finally, social. This is the realm of home life, financial barriers, school performance, and relationships, and also at the root of many of the challenges that some of the kids described earlier today face. So when these complex issues are approached by only one of these three components, success is much more challenging to achieve. And I think we really want to see more collaboration and access. So my final comment is that because of the needs in our schools, PrairieCare began a foundation called the PrairieCare Child and Family Fund. We started this in 2016. Hopefully you'll have packets that you can access or brochures within your packets. The fund's mission is to raise money to provide grants to schools to help them address training, education, and other needs in their staff and students. Last year, even though we just started, the fund received $1.2 million in funding requests from school districts across Minnesota, and we were able to fund about $120,000 in grants. The fund is having its annual fundraising gala on February 2nd, and everyone here is invited. And if you're unable to attend, if you look on the back of the packet, there's a QR code, and you simply point your phone's camera at that code, and you're able to give money on the spot and get a receipt. So we really appreciate the time and opportunity to visit in front of this committee, Madam Chair and Mr. Chairman.
Dr. Wall, thank you for your testimony. I'm going to, we've only got a few minutes left here. I'm going to exercise Chair's prerogative, however. You stated after defining many of the challenges that students are experiencing and then or bringing into the classroom, you stated that schools are becoming paralyzed in responding to these needs. Can you fill out what you mean by that more, please?
We hear about this frequently from families as well as teachers who are referring to our programs. And I believe they want to help, but just as was stated by one of the other panelists, when they're trying to teach and then they've got 3 or 4 kids that are acting up because of likely mental health concerns or social challenges, it becomes almost paralyzing to do the work that they're being asked to do. It's overwhelming. There's too much happening to either educate or adequately address the mental health related concerns. And that's where we offer free needs assessments so that the personnel can actually say, hey, we know a place, you can go there, they'll help you at least figure out what should be next in the sequence of your care. And so those are real challenges, and I think if you got hours of testimony from teachers, they'd probably give you hours of examples.
So what I'm hearing, Dr. Wall, is access to resources and, yeah, access to appropriate resources.
I think so, and I also would say that if they feel that we can't suggest or even ask questions about mental health, kind of the don't ask, don't tell equivalent of mental health, it becomes a real problem because they are identifying these kids who are struggling. And the impact of a completed suicide on teachers and the peers within those schools are enormous and lifelong. And they probably, in some cases, had an inkling that something was going on, but they didn't know how to ask or want to ask because they didn't know what to do next. And we think that that should be a barrier that's reduced.
Thank you very much. Any other questions? Representative Erickson.
Thank you, Mr. Chair, and thank you very much for your presentation. I know I've had friends who have used your facility, and it's a marvelous resource. But to what extent does PrairieCare, with their patients or their clients, work with the family?
We think.
Dr. Wall.
I'm sorry. The family component is incredibly important. We actually give within our programs a free multifamily group, which allows parents who are struggling with their kids and their mental health concerns, the parents to come in with one of our therapists sitting there in the room with them to be able to help ventilate those challenges. And we also work with them during individual family therapy. So identifying the kiddo who has the mental health concern sometimes really misses the point. We see that. We see parents struggling with multi-generational abuse, whether substances or trauma, and then this passes on to the kids. The kids just don't have the capacity within their development to be able to appropriately frame it, and they become the weakest link in that chain, and they suffer, and we identify it.
Representative Erickson.
Thank you, Mr. Chair.
Okay. Members, we have reached deadline, but there clearly is more interest in this topic. I would urge you to search out any of the testifiers today after we close here briefly to answer more of your questions. Dr. Wall, thank you very much for being here today. For members of the Education Finance Division, our next meeting is tomorrow at 9:45 a.m. We'll begin with presentations by the House Research staff, and then education organizations will each get 2 minutes to introduce themselves. We announced this last week, and a number of you I know have reached out to Ms. Burt to get yourselves on the list. If you have not and wish to, please do that. Representative Chair Youakim.
Yes, thank you. Real quickly, I have everybody's attention. Education organization, we're meeting tomorrow for Education Policy Committee, normal time, normal room. And we'll hear from the education organizations first, real briefly, try to get through the rest of the list. But we also have a great presentation with the Search Institute and the Bar Center to talk a little bit more about the barriers our kids are facing to their learning, and a lot more about building assets and painting that picture of the kiddos that are in our classrooms. So with that, we're adjourned.